Hello everyone. So yeah, my name's Sam. I'm from Pathfinders, and I've got also got lived experience of Duchenne muscular dystrophy. And yeah, claim to fame is that I am actually the silhouette in one of the videos. So that's a little bit about me. So our first guests will be Dr. Jarod Wong and Benjamin James. So Jarod is senior lecturer at University of Glasgow and is a consultant pediatric endocrinologist based at the Royal Hospital for Children and has been involved in national and international groups to develop standards of care for people for bone and endocrine issues from people with DMD. We've also got Benjamin James, who is a Duchenne patient advocate and a freelancer with Pathfinders Neuromuscular Alliance, who's worked previously in healthcare communications. They're now working on different projects supporting the Duchenne community on a range of things. And Benjamin also provided the voiceover for the free short videos that we are going to talk about today. So without further ado, I'll pass you over to our first guests, Benjamin and Jarod.
Good evening, everybody. Benjamin and I are going to do a double act. This is the first time we've tried that. It might work or it might fail disastrously. So bear with us. Next slide. Benjamin, over to you.
Yeah, so thanks for joining the Bone Health webinar today for the new bone health guidelines for adults with Duchenne. And like Jared said, we're going to present together. And throughout this, we're going to use case studies to illustrate the guidance and provide an overview of the importance of management of bone health in adults with Duchenne and the transition of bone health care to adult services. So in this example, we have James, who is about 17 and a half years of age. And yeah, he is one of our case studies, and he is on a regime of daily deflazacort, heart medication, and has had a bisphosphonate infusion for his bones. And he was on testosterone, but this was stopped age 16 as he completed puberty. And now James and his family are starting to ask about transition and the plans for bisphosphonate infusions. Next slide, please. Next slide. Oh, yeah. Um, so as James is in the transition period as a 17-year-old, there is uncertainty from GPs and doctors as to what to do. And this is where the new adult guidance comes in. So, Jared, I'm going to pass back to you now to just talk about the prevalence of fractures and osteoporosis complications in Duchenne and why these guidelines are needed.
So you're going to hear a lot more about James, and we're going to take you through a journey. We started at James, age 17 and a half. He's about to be transitioned to adult care. And as Benjamin said, that the clinicians are not quite clear how to manage some aspects of bone health in adults with Duchenne, specifically about bisphosphonate treatment and what that should be done. So fractures as a result of weak bones are common in people with Duchenne, and this is a combination of the weak muscles and also use of steroids, which are extremely important and has changed a lot about Duchenne in terms of improving care, but does have side effects. In our work using data from the North Star database, we've reported back in 2019 to show that clinical fractures in children and adolescents with Duchenne is at least about 4 times higher than healthy boys. Much more recently, when we looked at X-ray confirmed fractures in adults with Duchenne from the West of Scotland Adult Clinic in Glasgow, we found that clinical fractures in adult men with Duchenne was at least 2 times higher than healthy men. And clinical fractures were approximately 9 times higher in those treated with steroids. So extremely common. And also bearing in mind that when you compare with healthy men, and these are men with Duchenne in their 20s, healthy men fracture because of fights, because of falling from motorbikes, falling from ski, whereas all these fractures are from almost no trauma at all. So burden of fracture continues into adulthood. Next slide, please. The UK national guidance via the project called DMD Care UK, which some of you may have heard about, released in 2020, which is adapted from the international standards of care updated in 2018, suggests that people with Duchenne should have yearly bone density and also X-ray imaging, or can also be done by the DEXA scan, looking at spine fractures or spine fracture assessment. And these have been adopted much more widely since 2020. And these guidance also suggest that bone protective medicines in the form of intravenous bisphosphonate should be started once there is either a first long bone fracture or if there's diagnosis of mild spine fractures on these X-ray imaging. And these treatments should be completed until completion of growth. And of course, these guidance don't really tell us what happened after completion of growth. Boys do grow to become men, and therefore they are very pediatric focused. Next slide, please. And why is therefore there a need for guidance for adults with Duchenne in relation to bone health? So firstly, there is a need for guidance on long-term use of bone protective medicines. If we use X-rays to screen for spine fractures in boys with Duchenne, these spine fractures are very common, which means that a large proportion of young boys, older boys with Duchenne, on daily steroids particularly, will have spine fractures and therefore will be treated with bisphosphonate. And this study shows that on boys on daily steroids, daily deflazacort, by age 15, if you look carefully, 91% will have evidence of spine fractures or vertebral fractures. In the adult steroid-induced bone protective guidance for adults, these guidance recommend that bisphosphonate or bone protective treatment can be stopped when the underlying condition is managed, or if steroid is stopped, which we know, of course, is effectively not the case in Duchenne because we advocate for continuing of steroids. But there are some risks and long-term risk of using any medicine, including bone protective medicines. So there probably needs to be more detailed guidance on how we manage this population of young men. In adults, there is also other option of bone protective medicines other than bisphosphonate. But recently, we've published and found that there's very limited evidence in young adults under the age of 50, and specifically almost no evidence of these other alternative treatment in people with Duchenne. Next slide, please. So therefore, in around the 2021, 2022, it was decided that it will be useful nationally in the UK for us to develop some guidance for the monitoring and management of osteoporosis in adults with Duchenne, and by funding from Muscular Dystrophy UK and Action Duchenne with collaboration with the Pathfinders, we underwent a process where we looked at the literature, we looked at existing guidance, we conducted focus groups with with men with Duchenne, we surveyed doctors and clinicians in the UK and wider, and we got a group together to develop some expert consensus via this process called the Delphi consensus. Next slide, please. And these are all the people who are involved, and really shout out to Professor Ross Quinlivan, who some of you or most of you might know, who have done a lot for adults with Duchenne. Next slide, please. So these are the three areas which the guidance will cover and give more information. And we also have released three separate animation videos to explain those guidance, which I'll talk about a little bit more later, which have already been circulated online. Next slide, please. I'm going to hand you back to Benjamin because we're now going to quickly go through James's early years coming to his point in transition, and we can then talk about those guides.
Thanks, Jarod. So yeah, now we're going to, like Jarod said, have a bit more long-term picture of the management of osteoporosis in Duchenne and specifically James. So, James started off being fairly clumsy and falls sort of concerning his parents at age 2, and via multiple referrals, he was diagnosed with Duchenne at 5, and soon after that, he was started on steroids, in this case, daily deflazacort. Next slide, please. So James had the regular sort of bone density scans and X-rays, and as we know, this can be quite difficult sometimes to because you have to be still in the machine and all of that. but they always try and get the best picture of potential fractures or changes in sort of bone density over the years. Next slide, please. So James, around age 8, about 3 years after starting steroids, his X-ray started to show, spine fractures and bone density was becoming lower, or his Z scores were changing to show decreased bone density, which is predominantly it's shown in the spine and hips. Next slide, please. So he was started on bone protective medicines or bisphosphonates and given infusions every 6 months. And this stabilized the spine fractures and bone density improved with treatment. And the time can vary when you might start these bone protective medicines. But in this case, it seemed to stabilize, like I said, the spine fractures. Next slide, please. So at age 13, then James was started on testosterone to start puberty. And yeah, I just want to say here that not every young person is on testosterone, but a large number of young people are to help with puberty. In my case, I didn't need testosterone, but I know that's not the same for everyone. Uh, Next slide, please. Uh, so yeah, I suppose yeah, here I want to sort of say that uh, bone health management is vital as you move from pediatric to adult services with continual monitoring required. Um, and that is really important. I think now I'm passing back to Jarod to discuss the recommendations for management of osteoporosis therapy during transition in adults with Duchenne.
So the first bit of the guidance I actually want to talk about is what should happen as young men are transitioned from the pediatric service to adult around the age of 16 to 2021. James is almost 18, has been on bisphosphonate infusion since the age of 8, so you can see that he's almost close to 10 years of bisphosphonate. And James and his family are appropriately asking about what should happen about my care and what are the plans for ongoing treatment. Next slide, please. So, next slide, please. So this bit, we're talking about the transition process. What this guidance now say is that all adults with Duchenne at the point of transition, if they have a history of fracture or have been treated with bone protective medicines, either still having these medicines or previously been treated, should be reviewed jointly by a pediatric and adult clinician. This sounds very, to some of you, you might say that that sounds obvious, but we know this is not happening and we're keen for this to happen. And the point is that the people who've had these criteria, i.e., have a past history of fracture or have had treatment with bone protective medicine, there needs to be a discussion of a plan of whether these medicines should continue to be used or should be restarted. So making some sort of a plan. Next slide, please. And therefore, for this transition review, where possible, the spine x-rays or spine fracture assessment and DEXA bone density, if possible. Benjamin already alluded to the fact that it can be challenging getting these scans done, and I'll come back to that in a little bit. But they can provide useful information that doctors can use according to our guidance to decide on some of the important factors. Next slide, please. We suggest that if people have been treated for bisphosphonate medicines for a very long time, so if they've had fractures, if they've had, if they've completed puberty, either with medicines or without medicines, and have been treated for more than 10 years, if the risk to the bones is deemed low, and we give some guidance on what might be a low risk to the skeleton, maybe these medicines could be stopped for a period. And that's because there are some long-term risk of using bisphosphonate medicines, particularly for greater than 10 years. And in the elderly osteoporosis sphere, generally treatment is, where possible, limited to less than 10 years. Next slide, please. And some of these risk factors include whether the young person at that point is treated with steroids, whether it's daily or intermittent regimen, and some dosing, whether they're ambulant or non-ambulant. We appreciate most might be ambulant and non-ambulant at the time of transition, but we know the landscape of Duchenne is changing. There are also some guidance on the other factors like whether the spine fracture is stable, particularly on treatment, whether then new long bone fractures in the last few years, and other risk factors that may actually have an impact on the bones, like low testosterone level, diabetes, or medicines to treat reflux, like omeprazole, which can have small impact on bones and also bone density results. Next slide, please. So if with shared kit decision, if the decision is to stop treatment, we suggest that the spine fracture assessment and bone density should be repeated 2 years after stopping those treatment. And over time, treatment can be restarted if there are new fractures once treatment is stopped or bone density is actually dropping or declining when treatment is stopped. Whilst in pediatrics, we effectively only have intravenous or IV bisphosphonate medicine because that works, it's most potent. There are other options. Oral bisphosphonate might be an option. It is less potent, particularly in the pediatric setting, but sometimes it can be considered in adults with Duchenne. But bear in mind that we know that indigestion or gastritis is quite common with oral bisphosphonate. And there are different kinds of medicines which help target bones like denosumab, which also works quite similar to bisphosphonate in slowing down bone breakdown, but also other medicines like teriparatide and romosozumab, which helps build bones. But bearing in mind, there's practically no published studies of these other drugs for bone health promotion in adults with Duchenne. So those might be discussed, but that needs to be discussed in a case by case basis, and your clinician will discuss that with you. Next slide, please. So if James decides to stay on treatment beyond at the point of transition, there is a need to reassess, ideally with spine fracture assessment and bone density after another 2 to 5 years, just to see if things are improving, stabilizing, or deteriorating. So there's some kind of a review to see if treatment should continue. Next slide, please. Other factors which are important for bones is puberty and testosterone. As James has already mentioned, as Benjamin has already mentioned, using James's example, lack of signs of puberty in adolescent is fairly common, or quite common in boys with Duchenne. Sometimes after using testosterone to help development of puberty, some men with Duchenne, particularly those on steroids, might still have low testosterone level. However, our guidance says that it's useful to consider a period of testosterone therapy once these boys have developed puberty to see if their own puberty is kicking in. But that blood test for testosterone level ideally should be taken around about the time of 9 a.m. after stopping testosterone and to discuss testosterone treatment if testosterone levels are low on more than one occasion. Next slide, please. So to summarize, at the time of transition to adult services, there needs to be a joint review if there is a history of fracture or if there have been treatment with bone protective medicines. The joint discussion is about the need to carry on or to stop bone protective medicines depending on the risk of the individual. And if the treatment is to be stopped or discontinued, there needs to be some kind of a monitoring, and we gave some guidance for that. And the other issue at the point of transition is to review the need for long-term testosterone supplementation. Next slide. Benjamin is going to tell you another case study, and this time a man called Bob.
Yeah, so here we have another case study of Bob. He's 21 years of age, has Duchenne, and he's not on the same regime as James, but he has prednisolone 10 days on, 10 days off. He's on three medicines. He's had no previous fractures, and he's been managed in the adult clinic since 19 years of age. And previously, he's getting bone health check scans in the paediatric clinic. But now he's asking what bone health checks are needed because we have these recommendations for monitoring and management of osteoporosis and Duchenne. Uh, Bob can make an informed choice and um, decide what we want to do regarding bisphosphonate treatments. Um, and now I'm going to pass back to Jarod, I think, to discuss the next bit. Next slide, please.
Bob is a bit different because he's not had any fractures at the time of transition. So the next bit is talk about if you're already in the adult clinic, what bone health checks should you need and how should you manage or treat osteoporosis or weak bones in adults with Duchenne? Next slide, please. So we know that DEXA and some of these spine fracture assessments, while very helpful, can be very challenging. So whilst the pediatric guidance says this needs to be done annually, I think sometimes it's actually not very possible in adults with Duchenne. And what we recommend is that these bone health checks should be performed if whatever you find is expected to change clinical management. So in Bob's case, because he does not have any fracture, if in the adult clinic we do an X-ray and we find spine fracture, that will trigger starting bone protective medicine. So we think it's a good idea that Bob now has a spine fracture assessment and a DEXA scan. And the recommendation says that this can be repeated roughly every 2 years for dosing steroids. If there's severe back pain, that should be repeated. We also say that if there's not been a normal testosterone level before, Bob should also have a blood test for testosterone level. And of course, like all boys and men with Duchenne, vitamin D supplements is recommended, and a blood level of greater than 15 nanomoles per liter is recommended. Next slide, please. Very similar to the pediatric guidance, but really just to highlight it in the adult sphere, is if there's any low trauma or long bone fracture or if a spine fracture is diagnosed on X-ray, and if the man is not on any bone protective medicine, they should be referred for consideration of treatment. If they're already on bisphosphonate, there needs to be a referral to review if there is a need to change bone protective medicine. The decision might be to stay on the same medicine. If bone protective medicine is started or changed, there needs to be a review of the need for treatment and therefore repeating spine fracture assessment or bone density scanned 2 to 5 years after that. In these guidance, recognizing that by the time a man with Duchenne has scans and the bone density result is extremely low, these men have actually had many years of insult to the skeleton with steroids. And what we recommend is that if the bone density scan is very low, even without any fractures, there should be a consideration of referring to a specialist to discuss if bone protective medicine should be started. Next slide, please. So bone health check with spine fracture assessment and bone density should be repeated for every 2 years for dosing steroids if possible. There should be a need to check testosterone level if there are no previous normal results. You need to stay on vitamin D levels, and there needs to be a referral for bone protection medicine review if there are new spine fractures, long bone fractures, or very low bone density, even without fracture. Next slide, please. We know that bone density scan can be helpful but challenging to perform in particularly non-ambulant adults with neuromuscular conditions like Duchenne. Muscular Dystrophy UK have very kindly provided a research grant for us to conduct 2 pieces of research to try to improve DEXA scanning in non-ambulant people with neuromuscular conditions, particularly Duchenne. The first bit is, in fact, actually a qualitative research where I hope we've been working together with Suzanne and the team from Pathfinders to interview um, adult patients who are non-ambulant to share their experience of having a DEXA scan and how this can be improved. We're also looking for parents, carers of a young person who's non-ambulant. So please do take part. We've had rich stories from young people, but actually still struggling to find some parents. So if there's any parents, carers here, please do get in touch. We're also will be performing a clinical study where we're hoping to explore how possible it is to scan the bone density of the forearm whilst people are seated in the wheelchair, and this might actually improve the experience for people who are non-ambulant. Next slide, please. So we are looking for these people. So if you're 16 or older, diagnosed with a neuromuscular condition, so in this case, people with Duchenne who are wheelchair users or parents or carer of a person of any age who uses a wheelchair, please do take part. Next slide, please. And this is a QR code and also the email. I'll leave this on for a bit to get in touch, please, 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 because these are useful research which will help us provide lots of rich, important information for doctors and people who are scanning people like yourselves. Next slide, please. So in summary, this is the first consensus recommendation on management of osteoporosis, including what to do with bone health protective therapy during transition from pediatric to adult care. It stresses the importance of joint transition review and provides some form of a structure or framework for shared care decision making for long-term use or discontinuation of bone protective therapy when started in pediatric care. We're grateful to MD UK and Action Duchenne. These guidance have been endorsed by the British Society of Paediatric Endocrinology and Diabetes and also the UK North Star Network. We are in the process of publishing them and it has been circulated to clinicians. Next slide, please. We do have a similar webinar, but to clinicians next week, where we will launch these guidance. We believe that the last check is that there have been about 70 over clinicians from the UK who've actually registered for the webinar, so that we're excited. I also mentioned that we actually developed three separate patient information animation video co-developed with a group of men with Duchenne. We had Sam and Benjamin involved as well. These have been circulated via the patient organization website, but you can also find them on the Pathfinders website and also on the Pathfinders YouTube video. Everyone who's on here, please, please, please go and click and look at it and tell one other person who's involved, either an adult man with Duchenne or a clinician looking after a man with Duchenne or a family member about these videos. And we're hoping to publish this and we're hoping to share these guidance even wider.
Sam, thanks everyone for attending this bone health webinar. I hope you've got a lot from it. And I suppose I just wanted to say that, osteoporosis and fractures can and do occur in Duchenne. And from my personal experience, I know the importance of being aware of bone health management, to take ownership, feel empowered, and be confident to make the best decisions about bone health, guided by your clinical experts. Um, and I hope these guidelines in adults will help improve care standards and offer guidance to those living with Duchenne and their families and caregivers. And I really hope that through these educational videos that have been put together to communicate these guidelines in an easy to digest way and can be easily shared, will be a really helpful resource to communicate these guidelines. And I would highly recommend watching them if you haven't already and sharing them widely